Welcome back to Navigating Cancer. I'm Dr. Joey Bennett, again with Wendy Hall, and we are thrilled to have with us tonight Dr. Mark Fernandez, who is a general surgeon, been in Citrus County for 17 and a half years, deep roots in the community, and the entire group at Inverness Surgical Associates is wonderful to work with. We have a very good team approach, and today we're going to be talking about breast cancer again, and in this segment we're going to move into some of the changes that have happened surgically wise over the past 2 to 3 decades. I mean, we've made tremendous strides from every woman having to have a mastectomy to now having the potential for lumpectomies. We've moved away from bigger axillary dissections or checking the lymph nodes underneath the arm to sentinel lymph nodes. So we're going to get into that this time, and this is where you kind of take over because you are the surgeon. You do these and I don't. So first slide talks about the surgical options. I mean, kind of give us a little bit of background here.
There's been some major changes. A lot of people, they remember grandma or great-grandma who had the radical mastectomy, which is, I call plain old-fashioned nowadays. We really don't do that anymore. I mean, very rarely would anybody have a radical mastectomy. But it was the first thing that ever cured breast cancer. Right. They used to not be able to cure it. So they could cure it with a radical mastectomy. Everybody had radical mastectomies. And they said, well, hold on a minute. Let's not take that muscle tissue and let's not take quite so many lymph nodes. And then they compared those side by side, and they were exactly the same cure rate and everything. So they said nobody needs radical mastectomies anymore. Now it's modified radical. Then they tried lumpectomy, which we'll talk about, and that's just removing that part of the breast. And that was clearly worse. And the results were not even close. And then somebody said, and I don't know who, maybe you do, but somebody said, well, if you don't take the whole breast, let's try radiation therapy to the rest of that breast. And that brought the results and the survival to exactly the same as the modified radical mastectomy. So those are our two treatment options now. The modified radical mastectomy removes the whole breast and some lymph nodes. With the breast gone, there are options for plastic surgery reconstruction if the patient's interested in that, either immediately or later, 6 months or a year later, or never. And then, or lumpectomy, which leaves the rest of that breast. Many women prefer that because the outcomes are identical. And then you do have radiation therapy of one kind or another to that area of the breast or to the rest of the breast.
And I think that, what people need to realize is that the goal of a lumpectomy is to have a cosmetically nice looking breast after you have finished the surgery. And not all women are candidates for a lumpectomy. If women have small breasts and very large tumors, you're not going to be able to take out the lump and really preserve any breast tissue. If women have multiple areas in the breast that are abnormal, you're not going to be able to do it either. But for the most part, I think that, at least 90% of women that we see would be candidates probably for a lumpectomy. But some women don't want that, and it's a personal choice. I mean, even though you may be a candidate for having a lumpectomy, you may want to have the mastectomy.
I tell people that. They say, well, they'll say, which one's better? And I say, they're both better. It boils down to a personal choice. And I think 90% is probably accurate as far as who's candidates for, choosing one or the other. Inflammatory breast cancer is one where that's mastectomy, you can't even consider, or like you said, multiple areas. But far and away, most people can choose either depending on their personal preferences.
And I tell people that the biggest disadvantage of having the lumpectomy is they have to come see me for 7 weeks because you do have to do the daily radiation treatments. Another thing I want you to talk about, which I think has been a huge step forward in breast cancer, is the sentinel lymph node biopsy. I mean, give us a little background about the lymph node dissection, because that's a critical part of us needing to know what we need to know to treat the cancer.
Yeah, that's also a huge change. Back in the day of radical mastectomy, they took every last lymph node they could find. And it was very common to have a hugely swollen arm with either tingling or numbness or pain or swelling or all of the above. And you could get cancer in that big swollen arm. So they said, well, this is no good. Let's stop at a certain level. And it's basically the edge of that muscle and up to that vein. It's anatomical markers, but you might get 10 lymph nodes, you might get 20. But still a significant portion of women, I mean, not everybody by any means, but would have the tingling and the numbness and the pain and the swelling. So this new technology involves some tracer materials. There's a radioactive dye that we use and a blue dye, and when we use both, we're about 95% of the time we can find the first few lymph nodes. It's either 1 or 2 or 3, however many light up with these tracers, and instead of taking 10 or 15 or 20 lymph nodes out, we take those first sentinel lymph nodes, If those are cancer-free at that time, the odds of there being any significant cancer beyond them is very low. So then we stop at that level. We don't take additional lymph nodes, and then the incidence of arm complications is far lower.
I mean, I think if, for those of you who knew people who were treated, 25, 30 years ago, the risk of having a big swollen arm was extremely huge, and nowadays we really just don't see it that often.
And I mean, even 10 years ago.
Correct.
But modern management is to check the sentinel lymph node.
And I mean, and it's called the sentinel lymph node because it's the first lymph node that this area supposedly drains to. So if you can check that first one, I tell people they're like oil filters or air filters in series. If that first one is clean, the ones behind it probably are too. Once you've decided on your surgery, again, if you have a mastectomy, you may or may not have chemotherapy, and all of that really depends upon what the lymph nodes show and what we call tissue receptors, and those are a lot of the things that the pathologist tells us. If you go to the next slide, you'll see the typical way, and it may be another slide over, Bill, the typical way that we manage breast cancer with the radiation. And there's two different ways. One is with external radiation, which is the old standby, and the other is with accelerated partial breast irradiation. And if you go to the next slide, you'll see that in this slide you can see multiple radiation beams that are coming in towards the body, and they're designed to deliver a dose to the breast, and they treat the entire breast. One of the newer techniques is called accelerated partial breast irradiation, and I have two of the catheters here with me. This one is called Mammocyte, this one is called Savvy, and these are devices that the surgeon would put into the breast. Tell us how this would work.
Where we make the incision to go in and do the lumpectomy operation and remove the tumor. It's very important. All the edges are clear of tumor. The pathologist confirms that at the time. Then this catheter is placed into that cavity where the tumor was, or this one, and then the radiation is delivered with the highest concentration to the immediate surrounding tissue.
Yeah, and you can see on the next slide that we have, it actually shows a schematic of this being in the breast. The next slide shows the Savvy catheter, and this is the one that we have in our hand here as well. The beauty of it is that this Mammocyte catheter only allows for one way of treating the breast. The dose is very symmetric. The beauty of this one is that if it's close to the chest or close to the skin, every single one of these struts has the radiation source in it, so you can really contour the dose much better. A lot of discussion lately about this technique maybe being worse than the whole breast irradiation, and it does slightly increase the risk of the cancer coming back, but it's only a couple of percentage points. So,
yeah.
Big strides in the treatment of breast cancer. We want to thank Dr. Mark Fernandez from Memphis Surgical Associates for being with us. Thank you for joining us, and please come back with us next week.